Thank you, Shantanu, for a very erudite speech. Okay, so we are resuming. Shantanu, I was congratulating you for brief and erudite speech, and you have covered many important areas in a short span of time. Can you hear me, Shantanu?
Yeah, I'm there. Yeah, I'm
Yeah.
there.
Okay. Thank you so much. So, first of all, you have pointed out certain of the problems of diagnostic problem, like in some there may be longitudinal strain, may be normal. In some BNP deficiency may be there, so it may not be raised. You have already highlighted the issue of exercise in management, but can you highlight the issue of exercise during diagnosis?
Yeah. So I think, as I said, that there are a lot of gray zones in assessment of diastolic dysfunction in HFpEF, and this group of patients many times limit their regular daily activity. So we have to try to, and we see that, let's say the E by E prime is in the borderline zone, maybe between around 11, 12. So the point is, it is imperative to make them exercise either on a treadmill. You can do a modified Bruce protocol or a 6-minute walk test, and then subsequently get an echo. So we have seen that if we exercise them, which is called the diastolic stress test, you can have a TR jet or E by E prime goes off. And then it is imperative to have this advanced things. You can get a biomarker, and if there are role of LVGLS, you should always subgroup them into the phenotype group 1, 2, 3. Most common is 2. But if the patient has a left atrial enlargement and has atrial fibrillation, or if there is RV dysfunction, or if the creatinine is going down, then these guys are going to behave poorly. So we don't have much treatment there, but it is important that every reporting of ours should not only tell HFpEF, but also have HFpEF phenotype 1, 2, 3, whatever. So this can give you a prognosticate information how these patients are going to follow.
Thank you very much. And we have got 2 or 3 minutes left. In that time, somebody can put their question in the chat box, and Shantanu will be glad to answer that.
Yeah, I can see
Ashokda, do
Dr.
you have any comment?
Can you hear me?
Yeah.
Yes,
Yes,
you
Dr.
can hear. Antanu,
Yeah.
this is Dr. A.K. Kar.
Yeah.
I like to have some clarifications regarding 2 or 3 issues. Now you talked about the global longitudinal strain. Yes, we agree that global longitudinal strain is a important parameter, rather the newest parameter which helps in the assessment of LV function. But you see, if we consider the 3D ejection fraction, now do you think 3D ejection fraction is better than ordinary? I mean 2D ejection fraction and almost goes near to GLS.
Yeah, so there are two different things. So basically, what 3D EF is undoubtedly better than 2D EF by biplane, but so ejection fraction is always better by 3D than 2D. But the question is, strain gives you a function, while ejection fraction by 3D gives you an assessment by volume. So we have seen that even if the ejection fraction is normal, anything more than 50%, still the strain may be down, and that is the condition where which is called HFpEF with poorer with reduced LVGLS, or HFpEF with GLS to be preserved. And
Yes.
that's the reason we have started looking at the left atrial strain, and there is something called isolated atrial cardiomyopathy. I'm sure Dr. Mohan is going to
Yes, that's
attack, have some insights on those when he speaks next after two. But the point is, you are right. If you have access to 3D volumes and assessment by EF by 3D, it is better than 2D. I'm not touching upon 3D strain because it is not yet validated. We still have only information about 2D global launcher strain.
then Shantanu, I recently I went to one entity called high frame rate imaging for myocardial stiffness assessment, which is very important in a case of heart failure with preserved ejection fraction. What is your idea about that
So I
high
think
frame rate?
this is so the present machine which is available in the market. We get the 2D strains by the G's and the Philips at around 70, 80 frames. So but the guidelines say it should be between 50 to 70 strains. But what you are talking about is it's coming from Siemens. They go up to a frame rate of 1,000 frames per second in a 2D imaging, but it is in research. There was a young investigator award which got the best thing, I think, in AAC last year. The frame rates were at 1,000. So this is necessary for looking at the vortices. So we still don't have this in commercial level, but you are right. That is an absolutely different thing. It is only to assess the volumes inside the heart, the blood flow. Vortices are being picked up with high frame rate imaging. You are right. It is available now.
Any other questions?
If there is none, we can go to the next
Next speaker.
speech.
Yes,
Yeah.
yes.
So now we have another very eminent speaker from our Kolkata. He is the professor of cardiology in RKM and is associated with many other institutes. He is none other than Dr. Soumitra Kumar. And you know, the new anti-diabetic agent that was for the treatment of diabetes has now stepped like the Boli Raja in 3 steps. It has covered the heart without diabetes also and kidney region. So maybe hear something new from Dr. Soumitra Kumar on the emerging role of SGLT2 inhibition in heart failure with reduced ejection fraction. Dr. Kumar, please.